Welcome to today's webinar. My name is Jeffrey Jensen. I'm the director of the Paul and Margaret Brand Research Center at Barry University School of Podiatric Medicine. Today we're going to talk about the TCC EZ healing chamber and how to create an optimal environment for active wound healing. Here's an overview of the discussion today. We'll spend a couple slides talking about diabetes and the VIPs. We'll talk about offloading guidelines and evidence review. We'll talk about how the TCC EZ was developed as an effective offloading modality by design. Also, we'll talk about using the healing chamber to stop diabetic foot ulcer escalation. Kind of a nice way to look at the demographics of diabetes is in this chart. We know that in the United States there's between 25 and 30 million patients with diabetes. You can layer on top of that the number of patients with peripheral neuropathy, and that's between 10 and 15 million patients, which almost automatically launches a patient into the high-risk category. You start to layer peripheral vascular diseases. You look at the number of foot ulcers that are present. You look at the patients with critical limb ischemia, and ultimately we lose about 80,000 limbs per year related to diabetic foot ulcerations. Now conventionally, we look at vascular control, infection control, and pressure control as the VIPs. When you go through the literature and you look at offloading articles, all of them talk about the VIPs. You cannot get effective offloading and healing if you don't first address vascularization, infection control, and pressure relief. Now, sometimes we forget the pressure relief. In all of our clinical practice guidelines, we always talk about infection control and managing the vascular concerns. But sometimes we pay lip service to the pressure relief. And really, it's essential for wound healing if we treat pressure relief as important as vascular concerns and infection concerns. If you look back to the history of offloading, Dr. Paul Brand brought total contact casting to the United States in the early 60s. And we only had pockets of total contact casts being used throughout the country for the next 3 decades. Dr. Todd in the upper right corner had an academic center at Kern Hospital in Michigan, and he trained residents that went off and used casts. Dr. Harkless in the bottom right corner did the same thing at the University of Texas. But it really wasn't until the mid-2000s that Dr. Warner, with Diversified Clinical Services, wanted to standardize offloading throughout the entire country. It was at that point that total contact casts began to see high usage rates. So let's talk for a couple minutes about offloading and evidence review. In fall of 2014, consensus guidelines were established, and this was published in the American Podiatric Medical Association Journal. We brought together a consensus panel of physicians to Philadelphia in 2013. We developed 8 evidence-based guidelines utilizing the grade system for scaling, referencing 64 papers. There were 8 of those guidelines, but I wanted to just share number 4 with you today. Total contact casting is the preferred method for offloading diabetic plantar foot ulcers. It consistently shows the best outcomes and is a cost-effective treatment. This received a moderate grade of quality of evidence because there were less than 400 patients in all the randomized clinical trials, but the panel as a whole gave it the strongest recommendation for clinical use. If you look at examples of offloading devices, we typically divide them into removable devices and non-removable devices. We know that the Cochrane review from several years ago supported non-removable devices as yielding the highest and best outcomes. But if you look at the removable devices, you can typically see they're used in our clinics. You've got a half-wedge shoe, you've got cam walkers, you've got DH walkers or other removable devices. If you go to the non-removable group, in the middle, you've got the total contact casting systems, you've got the new TCC EZ system, and of course the instant total contact cast, which you apply a removable device and then make sure it cannot be removed. Interestingly enough, there's 3 different pictures here of devices that we use that have no evidence to support their use. The post-op shoe, the heel relief shoe, and then the tennis shoe or diabetic foot shoe, prevention shoe that typically is used for preventing wounds, not for healing wounds. So if you look at the evidence of all the removable and non-removable devices, there's no question that total contact casting has the most literature written about it and by far has the best evidence. Overall, as I mentioned before, there's less than 400 patients in the 7 randomized clinical trials, but across the board in these studies, you're going to see a healing rate of about 90% within 5 to 8 weeks. So let's talk about some clinical evidence utilizing the total contact cast that reiterates that it's a gold standard in the offloading arena. If you look at studies that were done 15 years ago in 2001. This is a study that was performed by Dr. David Armstrong and his team. They looked at total contact casts against removable cast walkers against half shoes. And if you look at two things that are very important, percentage of patient healed is about 90%, time to healing, in this case about 33.5 days. It's nice to see old studies validated. So in 2014, Dr. Lavery and his team in Texas did another study very similar. They were testing total contact casts versus half shoes versus a shear reduction boot. What's interesting is if you look at the same parameters, patients healed and time to healing, you still see almost 90% of the patients healed. If you compare that, it's almost equal to 14 years ago. And if you look at time to healing, it was 5.4 weeks. If you compare that to the study done by Dr. Armstrong, it's just several days longer to heal. So it's always nice to see validation of previous research. One of the largest diabetic foot ulcer analysis studies came from Dr. Fife, and it's through the U.S. Wound Registry. And they looked at 25,000 diabetic foot ulcer patients in a retrospective study. The number of patient visits was approximately 221,000 visits. And at the end of the day, if those patients were placed in total contact casts, they had 50% reduction in amputation rates and 50% reduction or more for infections. And those are statistically significant. So offloading with the TCC is not a repurposed fracture cast. It's very important to remember that there are three things that go into a total contact cast that you don't have with a fracture cast. Number one, the cast has to be ambulatory. Number two, the cast needs to be safe. And number three, it has to be efficacious in terms of wound healing. So the TCC was designed with clinician, financial teams, and patients in mind. We did lots of work over approximately 10 years at our clinic in Denver. We had NIH funds, we patented different ideas, we engineered the total contact cast such that it would deliver an ambulatory cast that was safe to use and had efficacy present. Here are the attributes of a total contact cast. You want to distribute the pressure from the bottom of the foot into the leg. We want to reduce pressure on the plantar surface by doing this and also reduce shearing forces. We want to eliminate the propulsive phase of gait by locking the foot at 90 degrees. If you do all of this and the patient ambulates, you can create that healing chamber. Ultimately, you get clinical efficacy and safety. Safety is paramount because these patients have neuropathy and any undue pressure or friction will create new wounds in those patients. Ultimately, we save time and money by healing patients quickly so they don't go through that cascade of events of infection, hospitalization, surgery, and rehabilitation. So this is a picture of a typical leg. And as patients ambulate, of course, they have ground pressures coming up from the ground. They also have shearing forces. Now in a normal ambulation, these are increased. These are increased from heel contact to the propulsive phase of gait. Now, if you do this with a neuropathic patient and they don't have any feeling, they can develop wounds like you see in this picture. This is a picture of a wound in the heel and a wound in the forefoot. So in order for these wounds to heal, we need to mitigate these forces. We need to decrease the shearing and ground pressures such that the patient has an opportunity to heal. How do we do that? Here's a total contact cast. This is the TCC EZ. You can see it encloses the entire foot, so we protect the foot from the outside environment. This creates our healing chamber. So if we have the cast on, and then we apply the outer boot, the patient is ready to ambulate. So when ground pressures come from the ground when they're walking up through the cast, where do they go? They get transitioned into the leg. About 65 to 70% of the pressure goes into the leg in a total contact cast. So at this point, you've got a total contact cast. The foot is protected from the environment. It's safe because the neuropathic patient has a total contact cast from the foot into the calf. Ultimately, we lock the foot at 90 degrees to eliminate the propulsive phase of gait so the patient can ambulate and heal at the same time. If we take the cast off, then the patient has a healed foot down the road. So an interesting quote came from approximately 20 years ago. It came from Dr. Caputo, and he said the total contact cast is the optimal device for protecting neuropathic ulcers during ambulation, and it differs from an orthopedic cast. And this was 20 years ago. So how does it differ? What are we doing with this cast that we're not doing with orthopedic casts? If you look at a traditional procedure We want to apply the cast in a prone position. Now, I'm not saying that you can't apply a cast in a seated position if a patient can't roll over, but putting the patient into a prone position should be the standard if at all possible. Now, this has a physiological rationale, which we'll talk about in a minute. It has a long history of experience, approximately 70 years. There's lots of descriptions in the literature for over 50 years, and ultimately the 7 randomized clinical trials we're referencing have used patients in a prone position for application. Why is this important? If we put a patient into a prone position, it's very easy to get the foot at 90 degrees to the leg. It also allows all the soft tissues to hang proximally. So if the patient's prone, muscles, adipose tissue, everything's hanging proximally so we can maximize the cone effect. It's, as I mentioned before, as soon as you bend the knee, it's much easier to put the foot at 90 degrees. Prevents edema. And with total contact, you eliminate high pressure areas within the cast that can create problems. And lastly, it allows the leg to be held up easy for application. But there's more to it than just the mechanical parts. We know that we need to keep the foot at 90 degrees and eliminate the propulsive phase of gait, reduce pressure and shear. But what I wanted to do is talk for a couple minutes about the micro effects. What is actually going on inside this cast? There was a wonderful study done in 2003. It was done by Dr. Pagesi and his team at Pisa, Italy, where they took 20 patients and they split them into 2 groups. One of the groups had crutches and a post-op shoe. The other group was placed in total contact casts. After 20 days, they did biopsies for histological assessment, and the next slide is going to show you what we found. You look at different aspects of a wound. Some are detrimental to the healing process and some are beneficial. The goal of this study through the histological assessment was to determine how much of each was in the control group versus the total contact cast group. So if you look at factors that are detrimental, hyperkeratosis, fibrosis, inflammation, cellular debris, you can see in the control group it was much higher than the total contact cast group, and it was significantly higher. If you look at the beneficial features, things that we associate with wound healing, healthy granular tissue, the leading edge of epithelial tissue, migrating from the periphery, new capillary formation. You see this was very minimal in the control group with crutches, but was substantial in the total contact cast group. What this really shows is that the patients in the control group were stuck in the chronic wound phases and they were not moving forward through normal healing processes. So the TCC is active therapy. The TCC creates a healing chamber inside the cast. And if you want to talk about wound management versus wound healing, we all know that debridement, infection control, all of these areas impact healing either positively or negatively. Likewise, inadequate offloading can impact healing negatively. We look at vascular concerns, lack of healing. Ultimately, we have a resource drain. There's no question with diabetic foot ulcer management, these patients come back often for treatment. This leads to 3 different things. The first is continuous need for treatment above standard healing times. The second thing is that it increases expensive and complicated treatments that we might not otherwise need to use. And lastly, it increases our chances of developing an infection that can ultimately lead to an amputation. Now, you may be familiar with Dr. Armstrong's stairway to amputation. What we want to do is we want to stop this right at the ulcer state if possible. We want to get the wound healed because we know that about 85% of amputations occur in patients that have had a wound. So the goal is to heal the wound with aggressive first-line therapies. Now, in 2010, Dr. Snyder was the lead author with Dr. Sheehan on his panel. They did a consensus document where they said the most practical way to heal more diabetic foot ulcers is to employ effective offloading strategies. So total contact casting does that. So if we do that, we can ultimately move towards offloading. We can get out of that resource drain of the circle and ultimately see these patients move on to being completely healed. So you go from wound management to wound healing. And it breaks the cycle. So what are the benefits of closing the wound faster? We all know this. If we get the wound healed, the chances of an infection are significantly decreased. If we get the wound healed, we know we're not going to move on to infections and subsequent amputations in an untimely manner. And also, we maximize patient and provider outcomes, which is crucial. So what are our barriers to total contact casting? With traditional casts, there were a lot of barriers. There was patient reluctance. The patients had complained of the heaviness of the cast. They had fears of falling. We certainly had clinician-related barriers. Those barriers included lack of learning curve to apply a cast, And certainly in our wound care centers, we couldn't tie up a room for 45 minutes. You need to have even patient flow through the clinics. So the TCC EZ really breaks down many of these barriers, because we've seen with patient-related concerns, there's no decrease in patient satisfaction with a TCC EZ. We know that it's easy to train clinicians. If you've got 4 or 5 clinicians working in your clinic, all of them can be trained in a timely fashion. And lastly, we talked about patient flow in clinics. We can incorporate patients with total contact casting right into the everyday flow of the clinic. So TCC EZ makes total contact casting easy. The TCC offers gold standard of care that can be accomplished in 3 easy steps. You can prep the patient with the primary dressing and then the padding over the bony prominences. You roll the TCC EZ cast and then apply the outer black boot. All of this takes approximately 10 minutes. Within 15 minutes after that, the cast is dry and the patient can ambulate out of the clinic. It requires minimal training time. It's lightweight and the patients appreciate that. Ultimately, you see if TCC EZ is used in clinics around the country, 4 times as many patients are casted than if that clinic just uses traditional TCCs. The TCC EZ healing chamber, here's a cutout where we can actually see what's going on inside the cast. You can see the intimate molding of the cast with the foot and the leg. You can see where the pressures are distributed throughout the cone of the leg. You can see the breathable cast material, which makes the cast light and cool. And also, naturally, you can't take the cast off. It's enforced patient compliance. All of these factors together play a part in healing patients quickly. So it takes approximately 10 minutes. We create the healing chamber with the TCC EZ, and it's time to heal. We really appreciate you participating in this webinar today. Thank you very much.